Welcome to The Explainer. Today, we're going to tackle one of the most common things you'll see in the clinic, the chronic cough. We're going to build a solid, systematic framework to help you evaluate and manage it like a pro.
And this is no small thing. We're not talking about just a minor annoyance. A chronic cough affects a huge chunk of the population, up to 10 or 12%. So yeah, you're definitely going to see this, and it can be a real diagnostic puzzle.
So picture this. You see a patient on your schedule. They've been coughing for what feels like an eternity, and they are looking at you for answers. So where do you even begin? Well, that's exactly what this explainer is for, to give you a clear, step-by-step game plan you can use every single time. Here's how we'll break it down. We'll start with the very basics of classifying a cough. Then we'll jump into the initial workup, nail down the 3 biggest culprits, and then talk about what to do when things get a little trickier. All right, let's jump right in. The absolute first step, before you think about anything else, is to classify the cough based on how long it's been going on. Just checking the clock, so to speak, is your most powerful first move. It's that important. So you can basically put coughs into 3 buckets. Anything less than 3 weeks, that's your acute cough, like a common cold. Then you've got the subacute cough, from 3 to 8 weeks. That's often that annoying cough that just hangs around after you've been sick. But our real focus today is the chronic cough, which we define as lasting longer than 8 weeks. Making this one distinction right at the start is going to narrow down your list of possibilities like crazy. Okay, so we've established it's a chronic cough. Now what? Your next move is a really systematic initial workup. And the first part of that is all about safety. Before you start thinking about the common stuff, you have to pause and ask yourself, are there any red flags here? Any danger signs that point to something more serious that I absolutely cannot afford to miss? And these are the big ones to watch out for. I'm talking about coughing up blood, having fevers and night sweats, a new cough in a long-time smoker, things like that. Any of these should set off alarm bells because they might point to something serious like an infection, a malignancy, or significant lung disease. And that means you need to get moving on a much more aggressive workup, and fast. So once you're confident there are no red flags, your workup gets pretty straightforward. It really boils down to 3 core steps. First, a really good history and physical. Second, a super thorough medication review. And trust me, we'll see why that's so key in a bit. And third, for most adults with a cough lasting over 8 weeks, you're going to get a chest x-ray. Now here's where it gets really interesting. After you do that initial workup and it all comes back clear, the vast majority of these chronic cough cases, I'm talking up to 90%, can be pinned on just 3 conditions. So knowing these big 3 is the highest yield part of your evaluation, for sure. And here they are, the big 3. First up, you have upper airway cough syndrome, usually from postnasal drip. Look for constant throat clearing or that cobblestone appearance at the back of the throat. In the middle, you've got asthma, especially cough variant asthma, where the only symptom is the cough. And on the right, GERD, or acid reflux. Now, some people will have the classic heartburn, but, and this is super important, in over 40% of cases, it can be totally silent. Often this is because of something called laryngopharyngeal reflux, where just a little bit of stomach acid mist comes up and irritates the vocal cords, triggering a cough. For all 3, an empiric trial of therapy is often both diagnostic and therapeutic. So what if you've treated for the big 3, but your patient is still coughing? This is when you got to start thinking outside the box and expand your differential diagnosis. Okay, remember how I said that medication review was critical? Well, here's a perfect example why. ACE inhibitors are a notorious cause of chronic cough. It's typically a dry, non-productive cough, and patients often describe it as this nagging, tickling, or scratchy feeling. The good news is, you stop the med, and the cough almost always resolves within a few weeks. Another really important diagnosis to have on your radar, especially if your patient has a history of allergies or atopy, is non-asthmatic eosinophilic bronchitis, or NAEB. Now, it can really look and feel a lot like asthma, but there's one huge difference. And this is the key to telling them apart. Both NAEB and asthma can have eosinophils in the sputum, and they both respond really well to inhaled steroids. But the defining feature of NAB is the absence of airway hyperresponsiveness. To prove it, you do a bronchoprovocation test. In an asthma patient, their airways will clamp down, but in a patient with NAB, they won't. The test will be normal. So, what happens when you've done this whole systematic workup, you've treated for the big 3, you've considered these other causes, and the cough remains completely unexplained? This is what we call chronic refractory cough, or sometimes cough hypersensitivity syndrome. It's a diagnosis of exclusion. The prevailing theory is that the cough reflex itself has just become way too sensitive, like it's on a hair trigger. So at this point, our management completely shifts. We stop hunting for a cause and we start treating the symptom itself, often with things like neuromodulators or even speech therapy to help control that reflex.
So let's wrap this all up. This slide is basically your algorithm. Start with duration, screen for red flags, systematically work through the big three. Never, ever forget to check that medication list, consider NAEB, and finally, understand that refractory cough is a diagnosis of exclusion. Follow these steps and you'll have a clear path from that undifferentiated symptom to a specific diagnosis and a solid treatment plan. And that leaves us with a final thought. This concept of cough hypersensitivity syndrome is really changing how we view this problem. It makes you wonder, is refractory cough truly a symptom without a cause, or is the cause a dysregulation of the nervous system itself? This shift in thinking is paving the way for new and exciting treatments that actually target these neuronal pathways, offering new hope for our most challenging patients.